Welcome back to the deep dive. Today, we are zooming in, literally, to microscopic levels, to look at a piece of engineering that I think most of us just completely take for granted.
Until it breaks.
Until it breaks, we're talking about the human ear, but not from a biology textbook perspective. We're looking at it as a structural problem.
It's a fascinating piece of machinery.
Yeah.
We often talk about biological systems as like software, genetics, and signals, but the ear is pure hardware.
High stakes hardware.
Absolutely. It's hydraulics, it's leverage, it's acoustics. It is the only sense we have that's purely mechanical.
And that's exactly what we're unpacking today. We've got a set of source notes from ENT Made Easy, and we are going to look at something called the Wolfstein classification.
Right.
Now, on the surface, I'll admit this sounds incredibly dry. It sounds like a list you'd memorize for a med school exam.
I can see why you think that. And it is technically a classification system for tympoplasty.
Which is the surgery to repair the eardrum and the little hearing bones, right?
Exactly. But you're right. It's not just a list.
As I was reading it, I realized it's more like a decision tree for disaster management. It's a surgeon looking at a destroyed middle ear and asking, okay, what's still standing, and how can I MacGyver a solution here?
That is the perfect way to frame it. Wolfstein's classification, types 1 through 5, it's a hierarchy of damage. It starts with everything's mostly okay, and it goes all the way down to the system is catastrophically broken.
And for each level, there's a fix.
The genius of it is that for every level of destruction, he proposed a specific architectural fix. He mapped out the entire logic of repair.
So that's our mission for this deep dive. We're going to walk down that ladder of damage, type by type, and look at the really ingenious ways surgeons use graphs to rebuild this tiny machine.
Exactly. And to get this, we have to establish what the machine is even supposed to do. Because the goal isn't just to plug a hole.
Right.
The goal is to restore vibration. You have sound waves in the air, and they have to become waves in the fluid of your inner ear. The middle ear is just the bridge.
So let's quickly set the baseline. Before anything breaks, how does that bridge work?
Okay, so you have the eardrum, which catches the air. And attached to that, you've got the famous chain of 3 little bones. The malleus, the incus, and the stapes.
The hammer, anvil, and stirrup.
A literal chain, or more like a lever system. The hammer touches the drum, it hits the anvil pushes the stirrup.
And the stirrup pushes into the inner ear.
Right, like a piston. It pushes into the inner ear fluid and amplifies the sound. That's the factory setting.
Okay, factor setting established. Let's start at the top of the Wolfstein ladder. Type 1. This seems like the best case scenario, if you can call it that.
Relatively speaking, yes. In a type 1, the defect is strictly in the tympanic membrane.
So just the eardrum itself, a hole, maybe from an infection or a Q-tip accident.
Could be anything, trauma, pressure. But the crucial detail, and this is what defines type 1, is that the engine behind the drum is pristine. The aceticular chain is intact.
The bones are good.
Yeah, the bones are perfect. They're mobile, they're connected. The only problem is the door, the eardrum, has a hole in it.
So the fix seems pretty straightforward, just patch the hole.
Mechanically, yes. The surgeon takes a graft, usually some tissue from the patient's own muscle, and they place it to seal that defect. But even here, there's some nuance. Because the foundation is so solid, they have options.
What kind of options?
Well, they can lay the graft on whatever's left of the original eardrum, or if there isn't much left,
Yeah.
they can lean it directly against the malleus, the hammer, because the malleus is right there, it's structurally sound, and it acts as a perfect little tent pole.
Oh, that makes sense. You drape the new drum over the hammer to keep the shape.
You need that tension for a drum to work, exactly.
Yeah.
If it just flopped over, it wouldn't vibrate. So type 1 is patch the drum, lift it with a hammer, system restored.
Okay, that's the easy one. But moving to type 2, the decay starts to set in. The source says we still have a perforation, but now the hammer is in trouble.
Right, we're seeing the first signs of bone disease.
Yeah.
In type 2, the malleus is eroded.
Eroded, like it's rotting away.
It's usually from cardiac infection, or something called the clisteatoma. It's a cyst that can literally eat away at the bone. So the surgeon goes in and sees the handle of the malleus is it's damaged, useless.
But the next bone in the chain, the incus, that's still okay.
Correct, the anvil is still standing.
So you can't use the malleus as your tent pole anymore.
It's too short or it's jagged, so you have to move down the line. In type 2, the graft is placed deeper. They drape it onto the incus itself.
Or a remnant of the malleus, if there's anything left.
Exactly. But the target has shifted from the first bone to the second.
Does that change the hearing? I mean, if you're bypassing the first bone, don't you lose some of that leverage?
You do. You lose a little bit of that mechanical advantage. The lever arm is shorter. But, it's a trade-off. It's better to have a slightly less powerful lever that's connected than a perfect one that's not.
Good point. Connection is key. So that's type 2. Lost the hammer, caught it at the anvil, now we drop to type 3. And this feels like a big jump.
It is a big jump. Types 1 and 2 are sort of variations on normal. Type 3 is where we get into what I call salvage engineering.
Because now, the malleus is gone, and the incus is gone too.
Both of them. Missing. The hammer and the anvil are out of the picture. Maybe the disease ate them, or maybe the surgeon had to remove them.
So just picture that. You've got a hole in the eardrum, and behind it, where there should be this bridge of bones, there's just empty space.
Avoid.
And the only thing left is the stirrup.
The stapes,
Yeah.
the final bone, is just sitting there deep in the ear, plugged into the oval window, waiting for a signal that never comes.
So how do you fix that? You can't just put a patch on the eardrum. It wouldn't touch anything.
Exactly. If you just patch the outer hole, you'd have a sealed ear, but you'd still be functionally deaf. So the surgeon does something radical. They take the new eardrum and they lay it, essentially, yes, they collapse the middle ear. Instead of a deep room with a chain of bones, they make it a shallow room where the eardrum sits right on top of the final exit.
The source had a fantastic tongue-twisting name for this. Myringostapediopexy.
It is a bit of a mouthful, isn't it? But medical terms are usually just Lego blocks. Maringo is the eardrum, stapedio is the stapes, and pexy means to fixate.
You're attaching the drum to the stapes.
Maringostapediopexy, simple as that.
I love when big words actually make sense. But there's another term here I found even more interesting. Columella tympanoplasty.
Yes, and this is a really cool nod to evolutionary biology.
Explain that. Columella sounds like a pillar or something.
It refers to the columella, which is the single ear bone you find in birds and reptiles.
Then we have one.
Just one. We mammals have 3 malleus and Gaius stapes. Birds just have one straight rod, the columella, that connects the drum straight to the inner ear.
Wait a second. So by removing the broken malleus and incus and connecting the drum directly to the stapes, are we technically turning the human ear into a bird ear?
Structurally, yeah. We are reverting to a simpler single column system. It's less sophisticated, you lose that amplification power. It's not high fidelity hearing,
But it works.
but it works. It restores the connection.
That's incredible. We're devolving the anatomy to save the function.
It's adaptability at its finest. If you can't be a mammal, be a bird. At least birds can hear.
Okay, so that's type 3. We're holding on by a stirrup.
No.
Now, type 4. The source warns us. This is much more difficult.
Type 4 is the tipping point. This is where the damage is so bad that simple connection isn't enough anymore. We have to start thinking about physics.
So what's missing now?
Pretty much everything we've talked about. Malleus, gone. Incus, gone.
Yeah.
But now, even the Stabi superstructure, the arch of the stirrup, is also gone.
The stirrup itself is broken.
All that's left is the base, the footplate. Imagine the stirrup is an arch standing on a flat base. The arch is rotted away. All you have is the flat base plugged into the oval window of the inner ear.
So it's just a flat plate on the wall.
Exactly. And you can't just lay an eardrum graft on a flat plate. There's nothing to grab onto. But the bigger problem is something called phase cancellation.
Right, the source mentioned this. It talked about the oval window and the round window. Why does this matter so much?
Okay, let's visualize the inner ear. It's basically a fluid-filled tube shaped like a snail, the cochlea. And fluid is incompressible. If you push in at one end, something has to bulge out at the other end, right?
Like squeezing a water balloon. One side goes in, the other side pops out.
Perfect analogy. The inner ear has two windows. The oval window is where the sound is supposed to push in. The round window is the relief valve that bulges OUT.
Push in, bulge out, that makes the fluid move.
And that movement of fluid is what triggers the little hairs that tell your brain you're hearing a sound.
Okay, got it.
Now, in a normal ear, the eardrum and bones focus all that sound pressure onto the oval window. The round window is tucked away, protected.
It's shielded.
Shielded. That's the key word. So the oval window gets a big push, the round window gets nothing, and the fluid flows. That creates a phase differential.
But in type 4, with all the bones gone,
The sound waves just flood the whole space. They hit the oval window and the round window at the exact same time.
and with the exact same pressure.
Correct. So you're pushing on both ends of that water balloon at once.
And nothing moves.
Nothing moves. The pressures cancel each other out. It's an acoustic short circuit. You could have a perfect nerve, but because the physics are wrong, you hear nothing.
Wow. So the surgeon isn't just rebuilding a part, they have to restore that pressure difference. They have to play traffic cop with sound waves.
Precisely. And the solution in type 4 is just pure genius. They create what Source calls a cavum minor,
A small case.
a small cave. They place the graft specifically to cover only the round window area. They create this tiny new air pocket that connects back to the eustachian tube.
So they're building a shield.
They're building a baffle.
Yeah.
Yes. This small cave shields the round window from the sound, and they leave the oval window footplate exposed to the outside air.
So sound comes in, hits the exposed footplate directly,
Push it in,
but the graft blocks the sound from hitting the round window.
allowing it to bulge out into that new air pocket. You have artificially recreated the phase differential.
That is incredibly complex. You're building a new pressure system inside a space smaller than a dime.
It is unbelievably delicate. You need that air pocket in the cavum minor to be airtight but also ventilated, or the whole thing fails. But when it works, a person with basically no middle ear bones can hear again.
So type 4 is not about connecting bones, it's about hiding one window so the other can work.
It's acoustic shielding. That's all it is.
Which brings us to the final category. Type 5.
The outlier.
This one seems totally different. The problem isn't that things are missing. The source says the footplate is fixed.
Right. In all the other types, we assume the footplate could move if we could just get energy to it. In type 5, the footplate is frozen shut,
Calcified. Welded in place.
usually from a condition called otosclerosis. It's not budging. The front door is nailed shut.
So what do? You can't graft onto a wall.
Well, if the front door is nailed shut, you cut a window in the side of the house.
Sorry, what?
That is literally the surgery. It's called the fenestration operation. Fenestra means window. Since the oval window is useless, the surgeon drills a new opening into the inner ear.
Where? You can't just drill anywhere in
They
there.
target a very specific spot, the lateral semicircular canal.
Wait, the semicircular canals, those are for balance, aren't they? That's what makes you dizzy.
They are, but the fluid spaces are all connected. The balance fluid meets the hearing fluid. By drilling a hole of fenestra into that balance canal, they create a new entry point for sound waves to get into the system.
That sounds incredibly high risk. You're drilling into the balance organs to try and restore hearing.
It's aggressive. And I should mention, this is a bit of a historical classification now. Today we have stapedectomies. We can replace the stapes with a tiny piston, but as a concept, it completes Wolstein's logic.
If the natural opening is blocked, make a new one.
Make a new one. You drill the hole, you place the graft over this new window to seal it, and now sound hits the graft vibrates the fluid in the balance canal, and that wave travels down to the cochlea.
It's hacking the hardware.
It is. It's treating the skull like a chassis that you can just modify.
So let's just recap this ladder because seeing it all together is something else. Type 1, the patch. Just fix the drum.
Simple repair.
Type 2, the bypass. Skip the hammer, go straight to the anvil.
Bridge the gap.
Type 3, the bird ear. Skip the bones altogether, connect the drum to the stirrup.
The Columel effect.
Type 4, the baffle. The stirrup is broken, phase cancellation is the enemy, so you build a cavum minor to shield the round window.
Restoring that phase differential.
And type 5, the renovation. The door is stuck, so you drill a new window in the balance canal.
The fenestration.
It's a roadmap of how bad is it, followed immediately by, well, here's the workaround.
And that's why it's still taught. It teaches surgeons not to just look for one correct anatomy, but to understand the principles of sound transmission. As long as you can get a vibration into that fluid and give it a way to release, the brain can work with it.
It's amazing. I think what sticks with me, especially with type 4 and the cavum minor, is the precision. I mean, we're not just talking about cutting and sewing. This is acoustic physics.
Absolutely. If you place that graft 1 millimeter off, or if that air pocket doesn't inflate properly, the physics just don't work. It's structural engineering on a microscopic scale.
And it really makes you appreciate that right now, as you're listening to this, you have 2 functioning oval windows, 2 shielded round windows, and a whole chain of tiny bones just dancing in perfect sync.
And you didn't even have to drill a hole in your semicircular canal to make it happen.
Small mercies.
Indeed.
Well, that is the Wolstein classification. A descent into damage and a masterclass in repair. It definitely changes how I think about hearing. It's not just a sense, it's a mechanical process.
It's the only sense that relies on direct mechanical transmission of energy. Vision is chemical, smell is chemical, hearing is physical touch just at a distance.
That is a profound thought to end on. Hearing is touch at a distance.
And sometimes you need a surgeon to rebuild the finger.
Thanks for diving deep with us today. Check your ossicles, appreciate your phase differentials, and we'll see you on the next one.
Take care.